Dysfunctional uterine bleeding, or DUB, refers to bleeding from the uterus that is abnormal in duration, volume, or frequency. Though DUB is often the product of interlaced pathophysiologic factors, the Palm-Cohen cause classification system helps OB/GYNs identify specific DUB etiologies. The acronym stands for polyps, adenomyosis, leiomyoma, or uterine fibroids, malignancy, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not otherwise classified. Heavy menstrual bleeding, or HMB, is the most common DUB manifestation, and with some prevalence estimates north of 50%, HMB is the leading cause of iron deficiency, ID, and iron deficiency anemia, IDA, among reproductive age women in the United States. But despite the robust prevalence of HMB, and the fact that effectively managing HMB-associated ID and IDA has demonstrated significant benefits on patient-reported outcomes and obstetrical morbidity and mortality, most women are never diagnosed or treated. As such, diagnosis and evidence-based treatment of HMB-associated ID and IDA represents a substantial clinical practice gap for OB/GYNs. All women with HMB, defined clinically as menstrual bleeding that interferes with a woman's quality of life, should not only be screened for anemia, but also for ID. The earliest laboratory changes are reductions in the iron indices, serum ferritin, the storage form of iron, and transferrin saturation, or TSAT, the systemic transport form of iron. Reductions in hemoglobin don't occur until later. Early recognition and treatment of ID before the onset of IDA improves clinical outcomes. In terms of treatment, oral iron is the traditional first-line option for ID and IDA, but due to the slow repletion of iron stores and high incidence of gastrointestinal side effects associated with oral iron, the therapeutic placement of intravenous iron in the women's health calculus is now evolving. Intravenous iron repletes iron stores much faster than oral iron and without the bothersome GI toxicity, making it the preferred iron repletion strategy when time is of the essence, such as before a scheduled surgery or in the third trimester of pregnancy, and when ongoing bleeding is expected, as is the case with HMB and for pregnant women at high risk for postpartum hemorrhage, or PPH. Intravenous iron also garners preferential clinical utility through its unique ability to overcome hepcidin-induced functional iron block. Hepcidin, commonly known as the master regulator of iron homeostasis, is elevated after doses of oral iron and in the presence of inflammation, particularly hyperinflammatory states where pro-inflammatory cytokines drive increased production of hepcidin in the liver. Elevated hepcidin leads to reduced intestinal absorption of iron and increased sequestration into macrophages and hepatocytes, a phenomenon sometimes referred to as pathologic sequestration, ultimately resulting in functional iron deficiency. While oral iron has limited efficacy in the presence of hepcidin, intravenous iron circumvents reduced intestinal absorption via bypassing the GI tract and overcomes restricted ferroportin transport by saturating serum transferrin, loading macrophages, and upregulating IRP1 and IRP2, which subsequently increases ferroportin expression, overwhelms functional iron blockade, and consequently improves ID and IDA.